couple quick announcements before we get started today. Thanks everyone for joining on. Delighted to have Dr. Naomi Kaplan talking about lymphedema management, former fellow who's done a really great job in just bringing this really important topic to us, and we're looking forward to it. Just want people to know there is no lecture next week, so if you log on, you're going to be here by yourself. We've got a lot of spring break and vacations and absences, so we will have the week off next week. So with that, Naomi, I will turn the floor over to you, and the podium is yours.
Thanks, Dr. Mulder. Thank you, everyone, for having me. Thank you, Susan. I think this is the third year that I'm doing this, which is really exciting. I mean, it's been the fifth year of my practice. I was really blessed that I got to do an elective with a lymphedema therapist at Trinity Muskegon when I was a hospice and palliative fellow. And that really informed what I do now. And I see lymphedema patients every single day at work. I think we can make a really big difference when we know what to do for these patients. So let's see. There we go. No disclosures. So we're gonna kind of describe the pathophysiology of lymphedema, the different types of lymphedema, primary versus secondary, cancer-related versus non-cancer related. Describe some of the clinical measurement skills for lymphedema, talk about a workup for these patients, and something that I'm really passionate about is evidence-based precautions, because there's a lot of non-evidence-based precautions that we're still spouting that we probably should not be. We want our patients to be, informed in a robust manner. So our lymphatic system, right, it's a part of our cardiovascular and our immune system. So the lymphoid system is made up of, we have lymph vessels, lymph nodes, lymph, which is protein-rich fluid. And then we actually have lymphatic organs that we don't always think about, which is our tonsils, our thymus, and our spleen. We have deep and superficial components. So a lot of our deep lymphatics are in our abdomen and our pelvis. Lymph flow is unidirectional, one-way valves. And essentially, if you think of your body kind of like quadrants, your right head, your right neck, your right arm, your right torso drains into the right lymphatic duct, and then the left head, neck, left upper extremity, but then also your both of your legs and your right and left torso are draining into the thoracic duct. So what are the kind of different ways that the lymphatic system can be affected? So either you have so much volume, so much lymph fluid that the lymphatic system sort of gets overwhelmed. It's like a high output. So that would be lymphedema. So I have a lot of patients like post-operative orthopedic patients. Or you can have a primary or secondary defect in the lymphatic system. So you have a normal amount of fluid, a normal amount of lymph, but the system itself cannot process it either due to a primary or secondary defect. And then you also get lymphedema in that way as well. When you have this long-term buildup of interstitial lymphatic fluid, you get subcutaneous fibroadipose production. So like the tissue and the skin can get hard and fibrous. That means that the disease is more advanced. So it's a chronic condition. It's not life-limiting, but the natural course is for it to get worse over time unless we're actively managing it. It's a heaviness, not true pain, unless obviously it's very heavy, in which case you can get musculoskeletal discomfort. But it's more of a heaviness, an aching, a tightness. If people are describing other stuff, like more like neuropathic pain or other kinds of pain, I want to rule out other differentials. And then obviously it can be really functionally impactful, limiting walking, limiting the activities of daily living. So lymphorrhea, which I kind of describe, it looks like rain, right? It's not serosanguinous. Like lymphorrhea looks like it's clear like rain. So it's leakage of lymph fluid. Sometimes you get vesicles and then you get the lymph fluid, and eventually you're developing a hyperkeratosis of the skin. Cutaneous ulceration is not typical. They might have a diabetic ulcer, they might have an arterial or venous ulcer, but lymphedema, like itself per se, is not associated with ulceration. and they have up to ninefold increase in developing cellulitis, which obviously can lead to the risk of sepsis, which can be life-threatening, obviously, if it's not treated in a timely manner. So you can see here, I don't have my presenter notes, but I've done this quite a few times. So we have, if you see image A, the patient has left lower extremity lymphedema. So, maybe they had some lymph nodes either removed or irradiated in their left groin inguinal region, for example, from cancer. On the right, on figure B, is a right upper extremity lymphedema. This is probably cancer related in a female. Um, C is right lower extremity lymphedema. Like I said, this may be due to like an abdominal or a pelvic cancer with damage to the inguinal lymph nodes. And then image D is someone with probably like, super, super morbid obesity. Obesity induced lymphedema. I'm trying to use that terminology more in my notes, OIL. There's a really up-to-date article on obesity-induced lymphedema that has really informed my practice recently. So those are kind of what you might be seeing in clinic. So primary versus secondary, which is what we talked about. So the lymphatic system itself, the structure of the system is affected. Primary, so you have an error in lymphatic development. So we might see this in children. I do have a few children in my practice. So pediatric lymphedema is pretty rare, 1 in 100,000. It can be childhood onset. There is more of a preponderance of males at birth, and then girls more like as tweens that it presents. Secondary, so an acquired injury to normally developed lymphatic system. So everything started out, and then the number one cause in the whole world is filariasis, which is a parasite. We do have filariasis in the Americas. I think in the Dominican, Haiti, a few other countries. But we just don't see that very much in the US. I've never had a patient who's ever had filariasis. But that's just because, like I said, of my geographical bias. And then if patients have cancer treatment, so resection or dissection of lymph nodes, and then even if you have, like for example, the surgery for breast cancer, and then the area has radiation that increases the damage to the lymphatic system. And then, if, for example, if you're in a motor vehicle collision, some people can have trauma to their lymphatic system. Typically, patients with cancer develop lymphedema within 5 years of treatment, and then mostly in the first 3 years. I have seen patients actually further out, like 7 years, but then they had a particular like trigger for it to present so late. And it was probably, I mean, it was subclinical for a while. Lipedema, I don't want to dwell on this too much, but this is a differential. Large amounts of subcutaneous fat in the upper and lower legs due to, so that it's the adipose cells, there's hyperplasia and also hypertrophy. The pathophysiology is complex, and we're kind of still figuring this out, but suffice to say, it's majority female. It's usually familial. They'll have a first degree relative. This is a clinical diagnosis. You really just have to train your eyes to see lipedema, which I've done, and it just takes the reps. You don't need to do imaging. In particular, lymphoscintigraphy would be normal. Obviously rule out systemic disorders, and then rule out whether you think it's actually lymphedema. That being said, if you have lipedema and you also have obesity, you can get lymphedema superimposed. So you can have both. Coding, there is a code in our Epic for lipedema. But that's been a bit tricky over the years to get this coded properly. I just want to see, and I did too many slides on this. So different stages, 1 to 4. So stages are like the severity, and the type. There's stages of severity. Type is a location in the body. So is it, from the waist to the knees versus the waist all the way down versus just the waist and the thighs? Also, if there's arms affected, so those are the different types. So you train your eyes to see that. Um, but there's this disproportionate symmetrical accumulation of fat in the bilateral lower extremities. And then you have this cuffing. So you can get cuffing in the wrists or cuffing in the ankles. I think that is well illustrated in that image in the middle. That she has cuffing. Another way to describe that is like pantaloons. So that kind of it's like the fat kind of billows out and then it tapers and becomes very narrow like a cuff. These patients have usually a dramatic waist to hip ratio. You can kind of describe it as like a two body effect. They have this like very narrow torso and then big like legs. Um, if you have a true, just pure lipedema with no lymphedema, your stemmer sign will be negative, but I'll talk to you about what a stemmer sign is. And then actually those areas with the pathological fat deposition, hyperplasia, hypertrophy, usually they're very easy to bruise. They can be painful and tender, typically resistant to diet and exercise. There is some interesting research now, and I've been giving some patients a handout about a high protein, low carb Mediterranean style diet to try to actually um, work on the fat cells from the lipedema. So there are like I said, there's quite a few articles right now about kind of taking that approach to diet. The tissue may feel granular, sandy, nodular. Um, Patients can have loss of conditioning, just kind of very fatigued, low energy. There can be some hormonal associated progression during pregnancy and menopause, or like I said, the hormones kind of influence the condition. So that's it, thankfully. But like I said, if you can train your eyes, I think the cuffing is a good sign to notice. And also, if you've seen lymphedema enough, you start to notice what's not lymphedema. If the legs are not what you expected to see, just consider, okay, is this actually lipedema? Okay, so lymphedema staging. Um, The percentage volume increase, which you see on the right, that assumes you know what their volume was at baseline, which often we don't know. Although more and more, I do have surgeons sending me patients for baseline measurements pre-operatively. That's very helpful. You can have either mild, moderate, or severe stage depending on how much volume has gone up. Um, but then you have your ISL staging, which is more kind of gold standard. So 0 is a subclinical state where swelling is not evident, despite impaired lymphatic transport. And we're actually, the way to find stage 0 is to do bioimpedance spectroscopy. Stage 1 are kind of patients who they tell me, well, if I put my leg up, my swelling improves, or if I go to bed in the morning, my swelling's improved, or I have some swelling, but minimally pitting, then I'm thinking stage 1. I'm thinking that's mild. Try to give the patient lots of reassurance that, it's early. Stage 2 can be 2A, 2B, or call it 2, late 2, whatever you prefer. So my patients who are 2A, it's like they have swelling all the time and it's pitting. Versus my patients who are 2B, those are patients who, like I said, it's more advanced. So they might have some pitting, but that's kind of transitioning into fibrosis, into hardening. And then 3, which I think is sometimes a little bit over overdiagnosed. The big thing for 3 is you get these warty overgrowths, which are papillomas, which I'll have a picture of coming up. Okay. So most of the people I would say you're seeing are 2A or 2B usually, or if they're particularly vigilant, they might be a stage 1. And if they're uncontrolled, and it's been years, then they're gonna have people presenting as stage 3s. So that's a stemmer sign. If you pinch at the base of the second toe, you can also do it in the hand. You should be able to pinch the skin. If you cannot pinch it, that is a positive stemmer sign that is pathognomonic for lymphedema. That does not mean that if you don't have a stemmer sign that you can't still have lymphedema. But that's kind of, you should always be checking for a stemmer sign. So things that will kind of give you a clue that this seems like lymphedema is that the extremities are affected, the arms and the legs. It's in the distal extremity. Um, Pitting emerges at stage 1 and stage 2A. Positive stemmer sign, like I said, is pathognomonic. We're looking for circumferential overgrowth, so it's the measurements around the limb. If you see any signs that they have had, cancer treatment, for example, scarring, kind of radiation, skin changes, that might give you a clue. These patients typically do not have ulcerations unless they have some concurrent arterial venous diabetic disease. Um, so BMI 50, actually, lymphedema, obesity-induced lymphedema, OIL, can emerge with a BMI greater than 40, and a BMI greater than 60, almost universally, patients have lymphedema. Um, I actually changed one of my smart phrases for a BMI over 40 because that's really when the risk goes up. And then 60, essentially, everybody has lymphedema. And I see patients with BMIs over 60 all the time. And then lymphorrhea, we talked about that very clear rain, that clear lymph fluid that's trying to escape through the skin, through the vesicles. Pitting scale. Honestly, I just don't use this I don't use this on a day. I don't use this that much. Either they have pitting or they don't have pitting. The way that I kind of frame it for patients is if you have pitting, actually your lymphedema is going to be really responsive to complete decongestive therapy. If the fibrosis is more advanced, it's harder for it to be responsive to therapy. So patients are concerned about pitting, but pitting is actually a good thing usually. Because like we said, it's stage 1 or stage 2A. Um, so some examples here. Whoop, sorry about that. I'm going to move this over. Stage 3 lymphedema, I would agree with that description. So you see these papillomas, these warty overgrowths. That patient's definitely gonna have a positive stemmer sign. You can't pinch at the base of the second toe. They probably have fibrosis and hardening. The thing is, when things are hard, we think they're strong, but they're not. So fibrosis and the papillomas are usually actually very friable, and they can get injured easily, and they just bleed profusely. So you actually really have to, even though that skin seems hard and feels hard, you really have to protect it. And then we said you can get hyperkeratosis, hyperpigmentation. These limbs are not looking so good right here. And obviously this patient has pedal edema and obviously calf edema as well. They probably have toe edema. Toe edema is awful. Um, mm, there we go. Lymphorrhea, like I said, looks like rain. I have patients who are honestly puddling. They're pooling during our evaluation. But these patients also, lymphorrhea also responds very well to complete decongestive therapy. I'm going to try to really keep an eye on the time here. So venous stigmata. So the reason you want to know there's vein disease is I went to a conference a few years ago online, but essentially the kind of school of thought is that these days is if you have chronic venous insufficiency, by definition, you have lymphedema because the venous system and the lymphatics are developing at the same time embryologically. So if you have insufficient veins, you probably also have insufficient lymphatics. But that being said, if they have vein disease, that could be a target for, vascular interventions. You want to be able to identify that so they can see a vein specialist. So I do part of my workup as most of my patients, I do send them to vein clinic in Grand Rapids. So we've got the top right with the whiteness, that's the atrophie blanche, which is that white scarring, which you can get with vein disease. The hemosiderin, top left, I have patients who come with venous dermatitis, which is bottom left, which is usually responsive to topical steroids. In the middle, you have a venous ulcer. And then the bottom right, you got the lipodermatosclerosis, or like inverted champagne legs, as they describe them often in medical school. So these are things where you're like, okay, so maybe they have phlebolymphedema, i.e., lymphedema related to vein disease. And I want to see if they need any vein procedures that might move the dial a little bit with their leg symptoms before we kind of start treating the lymphedema. So, really 90% of this, 90% of what you're figuring out, you're doing during your evaluation with your history and physical. Gold standard. Um, Gold standard is nuclear medicine imaging, which is lymphoscintigraphy. Just for our people who are local, this can be done at Butterworth, and it can also be done at Helen DeVos. So pediatric or adult lymphoscintigraphy is available. Um, so they're using this colloid tracer and like a gamma camera. So I think this image illustrates nicely. Patient C has accumulation of radio tracer in the soft tissue. Uh, so then think of your differential. Okay, why are they swollen? So one of the things which sometimes they create this artificial divide, but really everything's connected in lymphedema, is that if you have a high output failure, so for example, so kidney disease, heart failure, liver disease, you may have a lot of fluid. So this high output failure, that fluid is going to overwhelm the lymphatics. Um, but also one of the things, so, and that's because of this the sheer volume. But after so long, if your system has been overwhelmed for that long, that high volume will cause permanent secondary damage to the lymphatic system anyways. Um, so like I have patients who I see for lymphedema who are in kidney failure, different stages of kidney failure, or even on dialysis. But that fluid, because of the kidney dysfunction, is probably permanently damaging their lymphatic system. Um, Patients who we can get into a vicious cycle. We talked about the risk of cellulitis, but then cellulitis begets swelling and inflammation, which begets lymphedema, which puts you at a higher risk of cellulitis. I have patients who have had multiple episodes of cellulitis, who've been hospitalized multiple times, and the way to break that cycle is to get the swelling down. And actually the pump, which we can talk about at the end, the pump actually has good statistics for if it's used consistently to lower the risk of cellulitis over the years. We already talked about chronic venous insufficiency. Things that you would want to look at as part of your workup. If they have cellulitis, you're concerned for infection, you might be looking at their white count and their CBC. CMP, I would look at for kidney function. BNP, in case they have heart failure. A duplex ultrasound, you can rule out a DVT that's causing extremity swelling. If I'm worried about, if I want to do imaging for venous insufficiency, at that point, I'm like, well, they might as well just go to the vein clinic. The vein clinic will image them and talk to them about their findings. So I don't usually do the venous insufficiency imaging myself. I leave it to the vascular surgeons. Echo, and like vascular consult, which I've said a million times. Okay. Uh, So different ways to do it. In the office, I will do just a quick ballpark. So tape measure circumference. So what I do, I used to do it a lot. I used to do too much measuring, which takes up time during your appointments. And then I stopped measuring, and now I measure again just so I can kind of gauge, kind of give the patients an idea of how much the difference is between their limb measurements. So usually so for example, for the arms, I would do the MCPs, the wrist. I do the forearm about 10 centimeters below the elbow, and then I do the arm about 15 centimeters above the elbow, and I would do that on both sides and compare. And then obviously, the lymphedema therapists do a much more detailed measurements, and they're usually going up from the fingertip more proximally by increments of about 8 to 10 centimeters. And then the rest of these honestly are more research based. Water displacement, you can imagine how much water does a swollen limb displace, and that will give you an idea of how big or how swollen the extremity is. The parameter is what you see here on the left, um, with this kind of light box situation. Um, Something, like I said, is really important if you can to get pre-operative baseline measurements because patients usually have one arm at least a third of patients have an arm that's larger than the other one by at least 5%. And that would kind of be confusing post-operatively. If you're right hand dominant versus left hand dominant, that can affect the size of your arm. So, things to take into consideration. If you can capture these patients preoperatively, it'll just give you a more exact idea of what's going on postoperatively. The LDUX machine, which you see in the middle, is kind of an example of bioimpedance, which we had an LDUX machine when I was training in Trinity, Muskegon. We're trying to purchase one right now for Mary Free Bed. The bioimpedance spectroscopy, the thing, like I said, that the reason that we're trying to get one is that you can capture patients with subclinical lymphedema before it's clinically manifest. So, I think sort of my kind of millennial generation of physician or younger, we sort of take for granted that sentinel lymph node biopsy is um, a standard part of many patients' cancer care, that you can do the sentinel lymph node and only take out one or a few lymph nodes and know that you're not missing any micrometastases in the lymph nodes. But they had to do some very, very robust trials to prove that sentinel lymph node biopsy was as good as axillary lymph node dissection, which used to be that the majority of women would have, all of their lymph nodes stripped from their axilla, so 12 to 14 lymph nodes, and your risk of lymphedema is far higher. So it's really great that we don't have to do as many axillary lymph node dissections. Bearing in mind if patients have multiple lymph nodes involved, they're probably going to end up with the ALND. But if they only have one node, or no nodes, and they've only taken, like, if you've taken less than 4 lymph nodes, your risk of lymphedema is pretty low. Anything 4 or above, your risk is getting higher over the next 3 to 5 years. If you have radiation in that area, the risk is going to get even higher. So it is pretty amazing that we were able to go from, like I said, taking out a dozen lymph nodes to being able to take out 1 to 4 lymph nodes and just not affect the structure of the lymphatic system as much for these patients. Precautions. Precautions. Things that we tell our patients, predominantly women, although, I just had a male patient who also had breast cancer. But you need to consider like how people are going to change their lives based on what you tell them. And I think it's really important that we should be telling patients that are things that are evidence-based, because they will act on it and it may curtail their life. And, if you're telling them, well, you can't use an arm for blood pressure, blood pressure for lab draws, but they have something like cancer, they need a lot of lab draws. And then you're telling them, okay, well, they can only use the unaffected side, and that side's gonna get like just poked constantly. And just kind of that psychological burden, that anxiety that we place on patients by telling them these precautions. Precautions, like I said, really should be evidence-based, not historical and traditional. Um, there was this kind of survey of almost 1,000 women kind of in the late 2010s, and patients felt very negatively impacted, that their life was very negatively impacted by these lymphedema precautions, and that they all essentially perceive their risk as very high, which is probably not the case, because out of those 1,000, for sure, there was a bunch that were low risk and a bunch that were high risk. Um, So just that we're putting out this culture of fear, which what needs to change. Oh, there we go. Sorry, so the font is really small, but I think that makes a case. There's so many articles that do not substantiate these precautions. So avoiding blood pressure cuff on the at-risk arm. You can see none of these p-values are statistically significant. There's no level 1 or level 2 evidence that has a causal relationship between blood pressure measurements and arm swelling. Avoiding venipuncture or lab draws. Skin punctures do not cause lymphedema. Um, and if we say, okay, well, it doesn't cause lymphedema, but you could get an infection, your infection could cause lymphedema. Well, look, I mean, we do hundreds of thousands of lab draws every day in the United States. The risk of infection from getting a needle, from getting your labs drawn is like 0 to 0.5%. Avoiding air travel. This was based on like a level 4, and it was 6% of patients in a, retrospective study. Um, it's just very, very weak evidence. The other one, the next one down, is showing that 94% with no statistically significant change in extracellular fluid as per bioimpedance analysis. The next one, 760 breaths, no significant association with air travel and arm volume. Actually, if you wear incorrectly fitting compression garments and you fly, that will cause you an increase in lymphedema. So I always say to patients, if they're flying, just do exactly what you've been doing back home. If you haven't been treated yet, go enjoy your trip. If you've already been treated and you have, your usual compression garment, it fits well, your regimen, you just wear it normally, wear it like you would be if you were at home. So there's really not enough evidence to justify strict adherence to avoiding skin punctures, blood pressure measurements, or use of compression garments for air travel. If you want a really great review article, it's Asdourian. Asdourian is at Mass Gen at Harvard. Asdourian et al. Precautions for breast cancer-related lymphedema is from the Lancet Oncology 2016. I make all my residents read this article. Um, so I think that this is really, really important. And sometimes I feel like I'm shouting into the void, but I'm trying to kind of change the culture and educate patients as best as I can. So what are evidence-based precautions? So maintaining a normal BMI, avoiding weight gain, so focusing on kind of lifestyle measures, diet and exercise. Actually, I'm very excited that Mary Free Bed now has outpatient dietetics again. So I think that's an amazing opportunity. PT, OT, community exercise programs, like I said, a BMI over 40 in and of itself, the obesity itself is inducing lymphedema. And like I said, over 60, they universally will have lymphedema. Um, Avoiding infection and cellulitis. So, yeah, like I said, breaking this cycle of cellulitis and lymphedema, which can be really devastating for patients. And especially, I've had, like I said, patients who are hospitalized on a regular basis because they can't break this cycle. I always say to patients, like treat the affected area like your best friend. Don't freak out. But obviously, if you have an injury or a laceration, you want to treat it. You want to make sure it's healing. Normally, it's not getting hot or red or painful. And then obviously, kind of having we have very good wound services in Grand Rapids. We have Metro Wound, we have Trinity, and also Mary Free Bed, we have a wound clinic. Because they're a nidus for infection. Even if the skin is not infected, it can become infected. Podiatry is actually something that patients are really grateful. I give a lot of podiatry referrals because if you have onychodystrophy, onychomycosis, just really bad nails, they're also a nidus for infection, right? So I think people don't think of that all the time. Um, if anybody wants to know, anyways, I think Corwell. I'm sure there's very good podiatrists in town, but Corwell has some excellent podiatrists who take referrals. And the words of Dr. Tagian, who is one of the kind of the leaders in these lymphedema research articles, you want to avoid trauma, sauna, and cellulitis. Those are the true evidence-based precautions, and then maintaining a healthy body mass index. Like I said, I see a lot of patients with obesity-induced lymphedema. I think having just like open, objective conversation, if you talk about their weight, they've heard it before. You're not telling them something they've never heard of. You're not offending them. I think taking a really good lifestyle, weight management history from a patient, taking that health coaching approach. Um, if they have considered bariatric surgery in the past, would they revisit that option? There's some really good apps. So patients I have used MyFitnessPal and Noom. I usually give patients Dr. Greger's Daily Dozen. So it's 12 food categories that we can incorporate on a daily basis. That includes things like cruciferous veg, greens, vegetables, fruit, berries, whole grains, flaxseed, um, hydrating, exercise, and it tells you kind of the recommended servings. And there's also a free app on iPhone and Android for Dr. Greger, and it's that plant-based diet, which is really universally accepted in all of the major kind of health organizations in the United States that we should be focusing on a plant-based diet. And then this is a book that's on Amazon that if a patient kind of wants to have a reference at home, um, I tell them they don't have to buy it, but it's available for 20 bucks on Amazon, the Complete Lymphedema Management and Nutrition Guide, and it's written by a therapist and a nutritionist or a dietitian. It has 50 recipes at the back, which are also like really healthy. And then it has like good just reminders of how to wrap yourself, for example. Um, so that's kind of a text that I like a lot if patients are looking for some more reading. So complete decongestive therapy um, is the gold standard. And it's kind of a four-pronged approach, which is the therapists who have to be specially certified. So they're lymphedema trained and lymphedema certified, and they can be a PT, they can be an OT, you can even be a speech therapist. If you're a doctor, you can get lymphedema therapy certified if you want. But the four pillars are lymphatic massage, which they do for you, but they also teach you how to do it for yourself, and they teach you how to do a lymph node clearing, compression, skin and nail care, and exercise. Those are the four aspects of CDT. Okay. Um, so that's kind of what's illustrated here. We usually give people either upper or lower extremity exercises. If you look on the bottom, somebody has kinesiotaping. This is very big in Trinity Muskegon. We don't actually incorporate it at Mary Free Bed. There's sort of weak evidence for kinesiotaping, that you can do kinesiotaping, that it creates more space for the lymphatic vessels, essentially. So you kind of have, as you see there, the tape is cut into fingers, and then you have that anchor where you want the lymph fluid to be directed and where you want it to be draining. Like I said, there's pretty weak evidence, but a lot of patients seem to like it, and it's also pretty cheap, and they can do it for themselves as an extra tool. So it sort of depends how your lymphedema therapists were trained and whether they had that as part of their training. And then um, so just to clarify with you, so if you look at the bottom right, that person that's probably has a therapist is wrapping someone's leg. So that looks like an ACE bandage, but it's not. Those are short stretch bandages that we use during the complete decongestive therapy. So complete decongestive therapy is active therapy. The goal is for that patient to get their leg as small as possible and then to keep it that way long term with compression. Um, but like I said, this is an active phase where we're trying to get fluid off. And we're doing that with the massage and the lymph node clearing. And then you want these short stretch bandages because they create like a wall. So they're going to prevent that fluid from pushing out again. Whereas if you just had elastic compression, the fluid would push against the elasticity. So these, like I said, they're short stretch bandages. This is what you're doing during the active phase when you're working with a lymphedema therapist. And then long term, the mainstay of treatment long term, your maintenance regimen is going to be compression, and you either have stockings, which so that person has like a really cool like tattoo, arm sleeve, um, or you can do Velcro compression, which you see in the top right. And then a lot of patients wean off nighttime compression, but there are special nighttime garments. So those are in the top left. So if you have a sleeve or a stocking, like that picture in the middle, the patients are not to wear that overnight because it has elasticity, it has a tourniquet effect. You do not want them wearing that overnight. They either need to wear a night garment overnight or they can wear the Velcro overnight. So essentially Velcro patients could wear, up to 24 hours a day and just remove for hygiene, and for obviously washing the Velcro garment. The Velcro needs to have a liner underneath, right? Just like that stocking that you can see the patient is wearing, that stocking itself doesn't have much compression. It just protects the skin from the Velcro. So if we have a little bit of time, I just want to kind of say complete decongestive therapy is not for everybody. And I think that's where I can do a lot of triage as a physician, seeing the patients before they go directly to a therapist. CDT in the Trinity system is done 3 times a week. In the Mary Free Bed system, we do it 4 times a week. And I say to patients, is every time we want to get your leg a little smaller, a little smaller. And that's why we kind of see you very intensely because we want to build on that progress. And I also say, it's a burst of therapy. So usually that 4 times a week is for 1 to 2 weeks. But the big things are the patients, obviously, they need to get there. They need to have their schedule accommodated 4 times a week. They need to have transport 4 times a week. And then if you're coming 4 times a week, there's still 3 days of the week where you or a caregiver has to wrap yourself. And if that's not feasible, you're not going to maintain any of the gains the therapist is making. So there's a very significant chunk of patients where CDT, there's too many barriers. It's not a meaningful use of the patient's time or the therapist's time. So we need to kind of think of other approaches. In those patients, I'm thinking about, okay, can I get them Velcro compression? Can I give them good advice about elevating and skincare? And sometimes I give them some like basic massage instructions that they can do. But the investment does not have a return on interest in patients who have, like I said, difficulty with reaching their legs, difficulty with transportation. If they do not have a support network to help them with wrapping on the off days, it is really not worth it. If they have an underlying etiology, so obesity-induced lymphedema, because the obesity is driving the lymphedema, I often ask patients to kind of set this goal of trying to lose 10% of their body weight as an initial goal, because that's what's driving the lymphedema. So we can reverse some of that. And then also, if we are addressing weight, it's going to make the lymphedema therapy more effective. So there's better coverage, better insurance coverage these days for compression, but obviously your notes have to support it. But we can get these days compression coverage usually every 6 months, which is really amazing progress compared to previously. If you guys want to know my smart phrases, anybody can email me. I'm happy to share my smart phrase and kind of how I do my documentation. And then honestly, compression sleeves are pretty hard to get on. So it might be the gold standard, and maybe that you can get them a custom sleeve for their breast cancer related lymphedema. But bearing in mind, the best compression is a compression that they will actually wear. So I had a patient who has breast cancer lymphedema in their dominant arm, and they're 80. And then we got them a custom sleeve and it's tight and it's so hard even for me to get on for her. And I'm not with her all day long or every morning. So Velcro is not, Velcro is simply not as compressive as a sleeve or the stocking, but I think we have patients have much better compliance and adherence with the Velcro. It's really good also for patients who live in facilities. And it's hard for caregivers, either skilled or unskilled caregivers. It's hard to get it wrong. Um, so I'm a big advocate, like I said, for any compression is better than no compression. Consistent compression is the best compression. You decide what your patient can be consistent with. Um, so it's a kind of pretty pragmatic approach. All right, we got 10 minutes. Advanced pneumatic compression device, APCD. So the research is pretty industry biased. You can see this picture is taken from Tactile Medical. They do not pay me, but I have chosen to work with one pump company just because they're easy to work with, and I think they really try to support their patients and try to get coverage as much as possible. The pneumatic compression device, depending on the complexity, is either trying to mimic the venous system or mimic the lymphatic system. And I say to patients, this is the icing on the cake, the cherry on the sundae. You do not need a pneumatic compression device. If your insurance is not going to cover it or you can't afford it, the mainstay of long-term management is compression garments and doing your own massage and staying healthy and active. But if we can get this for patients, I think it's great. Like I said, the research is pretty industry funded, but they had some pretty robust research of reducing the risk of cellulitis. And I have had that play out in my clinical practice. Patients who have the pump have told me, oh, I haven't had cellulitis in 2 years now. The standard kind of clinically and from an industry perspective is that you wear an hour a day every day. And if patients have it, I really encourage them to lean into using it. Um, as you can see, so top left, he probably has head and neck cancer and maybe kind of lymphedema in that area. The lady top right probably has breast cancer related lymphedema. And then the bottom, he has some lower extremity lymphedema, maybe phlebo lymphedema. One of the things, let's go back. One of the things about these pumps is the more advanced pumps. So the guy on the bottom, he would probably have an abdominal piece if he had the Flexi Touch and more advanced pump, and it would also have more chambers, like the individual kind of parts of the leg piece. So you'd have a leg piece and an abdominal piece. And one of the things to explain to patients is that um, when they're doing lymphatic massage or when the pump is doing massage for them, you want to clear proximally. So you want to clear towards the center of their body and those deep lymphatics in the abdomen and the pelvis because you need somewhere for the fluid from the extremity to go. Um, so that's why the pump is going to start more proximally and then start working distal to proximal so that you're pushing the fluid somewhere that can receive it. That makes sense. Um, so like I said, the pump, yeah, I have a bunch of smart phrases also for the pump if you want to get the pump covered. That requires very robust documentation. It's taken us a few years to get really good. A really good smart phrase. And then, but the having a company to work with, I think is really helpful. And then obviously if the pump malfunctions, the patient reaches out directly to the manufacturer. Um, but the mainstay, if patients can't get this, it's not the end of the world. They should have some kind of long-term compression garment and some encouragement about having a healthy, active lifestyle. My other big thing, since I'm almost done and I have about 8 more minutes, um, is my big thing at the moment is giving people. So I give everyone Dr. Greger's Daily Dozen. So for patients who I think kind of are savvy and appropriate, I might recommend that book off of Amazon. I give a lot of patients the American Heart Association 6-week walking program which I think is really great. And I think I have made it a big part of my practice and also my trainees to say to patients, how far can you walk and how far do you walk? And we are in such a sedentary culture. I mean, Michigan is hard also in the winter, and we have a very elderly population. But you would be surprised, I think, the number of your patients who can only walk for 5 minutes for various reasons. So the American Heart Association, it gives you a 6-week walking program to get you from 5 to 35 minutes of easy walking. And I think that this is helpful for lymphedema, but also for so many of your other patients, or for other diagnoses. But remember that your calf muscle, um, your calf muscle is squeezing the fluid back into the circulation. Um, so I always tell patients you do your walking to get that calf muscle activated, to get that squeezing, and then you elevate your legs afterwards, right? Because I share a couple of patients with my colleagues who have ALS and who have lymphedema. They are sitting in a dependent position in their power wheelchair all the time. So gravity's acting against them, but they also don't have that calf pump mechanism to squeeze the fluid from their legs. And it makes it very, very hard to control the swelling. Um, yeah, keep getting your patients back on their feet. Sometimes if I have elderly patients who, and I think honestly, we are going to have soon to have an epidemic of um, elderly patients with obesity, with morbid obesity. So morbid is BMI of 40, super morbid is a BMI of 50, and super morbid is a BMI of 60. So I encourage you to use that in your documentation. But we are going to have so many elderly patients. And if the obesity is driving the lymphedema, I often don't send them for lymphedema therapy. I send them for regular physical therapy so that they can ambulate safely, so they can start being more active. Because if they're elderly and they're frail and they're obese, and maybe they use an assisted device already, like a cane or a walker, or are using a wheelchair a lot, getting them back on their feet is what's really going to move the dial with their swelling. So sometimes I think that's really more meaningful to a patient than having a therapist do some passive lymphedema therapy when you can start to address their underlying etiology. So the goal is really to empower patients to live functionally independently despite having a chronic lifelong condition and to lower the risk of associated complications. Please don't hesitate to email me if anybody wants to shadow. Also very open to that. Just kind of reach out. And it's very rewarding. And thanks for joining this morning. I think we're done. And these are some references.
Well, thanks, Naomi. You can go ahead and relinquish your screen there.
Sure.
I'll open it up for questions. What I really appreciate is uh, the very pragmatic approach that you take here. Sometimes we tend to get into the esoteric, and I think that there's just so many practical things we can do with our patients. And if I just kind of reflect back over my career, the number of times that we see people with lymphedema, recognizing there are things that I can do, perhaps should have done, didn't do because I didn't know. And this is just, I think, a really practical approach. And I just, everybody on the call, I'm sure that they appreciated the same perspective. I can do that. I can help to guide them. And next level, here are some resources available that I can access as well. So thank you for that. Questions, comments for Naomi? The PowerPoint will be posted this afternoon for the lecture for those that want to re-access and relive some of those special moments.
This is Rob. Hey, great talk, Naomi. Appreciate it.
Hi, Rob.
Hi, good to see you. Question, does lightweight or low compression extremity stockings on the legs help at all with those folks who have more, I don't know, I have some folks who are like the stage 2B, even 3, lymphedema. Does that help at all with a gentle compression, or am I just kind of treating
I
my
would really try to get them into Velcro. I think the Velcro
Velcro?
makes the most sense. I think, if you had light compression, like 5 to 10 millimeters of mercury, it might make them, I mean, in terms of quality of life, it might make them feel less heavy. Or is it doing much? I don't think it's doing much. Um,
Okay.
it might help with how their limbs feel. But I think Velcro honestly is pretty accessible to a lot of patients, bearing in mind they might have to get bigger shoes or slippers. Um, so I also had a patient so one of the things we didn't talk about are like kind of contraindications or precautions. So if you have peripheral arterial disease and your ABI is like less than zero point 0.5 or zero point 0.4, you really should not be compressing them. But I had a patient who had both. He had very severe arterial disease and he also had very severe venous disease and lymphedema. And kind of in terms of like just I said, kind of giving some compression, some support to feel better. That was a situation where I thought light compression was appropriate.
Okay.
Bearing in mind there are risks. The risk essentially is you want to lower the risk of ischemia, um, if you use too high compression in a patient with peripheral arterial disease.
And where do you order the Velcro? Does CareLink carry that?
Carolink does it. But there's a guy in town, who Brian Zylstra, he is a compression specialist, but he has a DME store on 44th. So Brian Zylstra is really great to work with. You need to have like really robust documentation. I'm happy to send you my smart phrase if you want to shoot me an email later. Um, and it's not I mean, to get the Velcro, it's not a big smart phrase, but you're going to have to link your diagnoses, make sure you have a lymphedema diagnosis, and it's just like a little paragraph for the Velcro. The pumps have the smart phrase is like, it's a lot, um,
Sure.
but Brian Zylstra is really good to work with, and he also knows all the kind of insurance, all the ins and outs and getting patients covered, and he does do patients who have Medicare. So I send everybody, to him.
Okay. So I have a
Mostly,
couple frail.
unless they are getting other stuff from CareLink already. And Mary Freebed has a CareLink, remember, on the second floor, if that's convenient for patients. Otherwise, there's a couple other CareLinks in town.
I have a couple frail people who just can't get out to outside appointments at all. That.
I think he does home visits.
Oh, really? Okay.
Yeah, yeah.
That'd be
Um,
great. Can you send me that contact information, or I can email you and then you can email me?
can you send me, Dr.
Okay.
Ritzy? Yeah, and
Yep.
I'll
That'd
shoot
be
it back
great.
to you, the
So
Awesome.
details.
Naomi, a couple of comments here that came through as direct messages. One, are saunas contraindicated in breast cancer patients, and are hot tubs in the same category?
Yeah. I consider them in the same category, and I say to patients, it's a quality of life. You know, if we were all Scandinavian and you were doing it every single day, I would say the research suggests you should not be doing sauna or hot tub every single day. If you're doing it a couple of times a month in the summer in Michigan to spend time with your family, I'm okay. Obviously if you're doing this, you have to make sure you have intact skin, no skin breakdown, and then I would really lean into your compression regimen after the sauna. So do your massage, do your lymph node clearing, put your compression garment back on. But I don't tell people you can never go in a sauna or a hot tub again because that's just not fair.
Okay, another question. What would be your highest yield recommendation to help symptom management, specifically pain? And this is in a resource limited scenario, in a declining patient like a rural hospice. In other words, you've got someone, out in the boonies and we need something. Any particular light compression that you'd recommend that could be a go-to for, an HPM doc that just needs
I
a go-to in their tool chest?
I'm really gonna say that with the insurance coverage now, even like rural HPM, you really should be able to get Velcro compression garments. And you can get them online or you can get them from whatever is the closest DME store. I don't think it's out of reach of anybody these days to get Velcro and to get good compression. Um, I mean, you can do, I mean, if you wanted to do the, Tubi grip. I don't know if the Tubi grip is really going to make you feel any better. I think the Velcro would make you feel better. And like I said, like it's so much better now that, since I think 2024, the Velcro coverage is a lot better. So if you want to do tuba grip, that's fine. I would try to go the extra mile. I don't, you shouldn't really, the patient or the institution, the facility should not be out of pocket these days for the Velcro. And it might be the basic kind. Um, but that's what I would recommend.
I'll lean on that for a go-to.
Someone said about using a DOF and a donor in the comments. I agree. I often order the Medi Big Butler or the Medi Butler, which are these wire frames, and patients can load their stocking or load their sleeve onto the donor. I agree that that's helpful. I would say that patient I had who was 80, who had breast cancer lymphedema, she brought her Medi Butler in and we loaded her sleeve, and it was still extremely hard to put on. But definitely for lower extremity lymphedema, and not make sure they don't have like, so sometimes when they come to rehab, they get like that thing to pull socks on. This is not the same thing. This is a wire frame where you load your compression stocking onto it, and then you step into it, and then you pull it up. So yeah, and you can get those if you're ordering from Brian's Isle, you're ordering from CareLink, you just say you want a wire frame or a Medi Butler for donning compression garments. But some patients can't use that. Some patients are still, their function does not support that, and you should use Velcro. And like I said, if you're in a facility, give them Velcro.
There you go. Well, thanks again. For those that might have come on a little late and missed the original announcement, there is no lecture next week. And so we will look forward to seeing you all here in a couple of weeks.
All right, thanks. Good to see you. Take care.
Thanks, Naomi.
Bye. Bye.